My name is Virginia Kaklamani. I'm professor of medicine at UT Health San Antonio. I'm one of the co-directors of the San Antonio Breast Cancer Symposium. I'm a medical oncologist. I treat breast cancer patients and also see patients that have a high risk of developing breast cancer. This is the 48th year that we have the San Antonio Breast Cancer Symposium. It's the largest breast cancer meeting in the world. This year we have a record attendance of more than 11,000 attendees and from more than 100 countries in the world. So this is a global meeting, and this is a meeting that merges basic science and clinical research. And this is really the power of the meeting. This year, the themes of the meeting were two. One is artificial intelligence and how we can incorporate that into breast cancer treatment and research. We saw several really great papers looking at prognosis and prediction and how AI can help us do both, which I think is something, it's the wave of the future. And then the second theme is breast cancer in young women. So I will highlight HER2CLIMB-05, which was a study that looked at patients that had metastatic HER2-positive breast cancer. They had received initial chemotherapy and anti-HER2 therapy, and then they went into a maintenance therapy with tucatinib, which is a tyrosine kinase inhibitor. And it showed that the patients that received tucatinib had better outcomes than the patients that were not on the tucatinib arm. This is an important study. This is a study that can help us avoid giving long courses of chemotherapy to patients with metastatic breast cancer, but also give them active therapy that can help decrease or prolong their progression-free survival, which is extremely important. So that, I think, is a practice-changing trial. We have tucatinib available, and we use it all the time for patients with metastatic disease, but this is a different setting. The second trial was the lidERA trial. And this was the first phase 3 clinical trial that introduced an oral SERD called giredestrant in patients with early stage estrogen positive breast cancer. And this is the first endocrine therapy that we've had come out in the past 20 years. So this was really huge news. We don't have giredestrant approved to date, but there are two trials that were presented this year, the lidERA trial and the AVERA trial, that both of them showed positive outcomes with giredestrant. So I assume that the approval will come pretty soon. And again, it'll be practice changing.
My name is Isabelle Bedrosian. I am a surgical oncologist. I am on faculty at the University of Texas MD Anderson Cancer Center, where I hold a tenured faculty position in the Department of Breast Surgical Oncology. I am also the national PI for the Alliance A11104 trial, which looked at the effect of preoperative breast MRI staging on local recurrence outcomes in patients with early stage breast cancer. It was designed as a very straightforward one-to-one randomized trial where women with early stage breast cancer, so stage 1 to 2, these are women that are most likely to have breast conserving surgery, who had hormone receptor negative breast cancer. So this is all women that would be eligible for lumpectomy. And we excluded anybody with a known germline mutation. So patients that met those criteria were randomized one-to-one to either receiving additional MR imaging beyond just a clinical exam and a mammogram and an ultrasound versus receiving no MRI imaging. So what the study's primary outcome, again, was to see the rate of local regional failure at 5 years of follow-up between the two study arms. And, we didn't really see any differences. We had presumed that the women that did not get MRI would have had a 10% failure rate based on the literature at the time that we were designing this study, which is back, in the early 2010s. And we were hoping to see that reduced down to about 2% in the women that had MRI as part of their initial staging evaluation. And what we ended up seeing was, roughly 94-95% rate of local regional control in the two study arms. So it didn't really meet our sort of pre-specified expectations of reduction from about 10% down to about 2%. And we saw that the two arms were very comparable in terms of their local regional control outcomes at 5 years. We did that analysis both in the group as a whole. Again, all these patients started off as being eligible for breast conserving surgery, but not necessarily all patients did not necessarily have breast conserving surgery. Those are two very different things. So some of the women actually in the process of the trial ended up having a mastectomy. And so we looked at the study again and removed the mastectomy patients and just did the women who did have breast conserving surgery. And we saw, again, no differences in the results that, both the women in the MRI arm and the control arm, local regional control was excellent at about 95% at 5 years. We also looked at other oncologic outcomes. So we looked at the rate of distant recurrences, no differences between arms. We looked at overall survival, no difference between arms. We also did some subset analyses. These were exploratory in nature. We looked at women that were under age 50 because we tend to think that perhaps that's a population that may have more benefit. They tend to have more dense breasts, so perhaps MRI may be more useful in that setting for appropriate disease delineation. But we saw no indication that MRI was especially beneficial in women under the age of 50. We also looked at the HER2 positive patients versus the triple negative patients in the study. And again, we saw no indication that MRI would be beneficial in either of those subsets. So we really couldn't find a subset where the MRI may have, looked like it had more utility in terms of improving local regional control. So, I think there's been a multitude of change in how care is delivered that probably accounts for the fact that at the end of the day, our observed rate of local failure in the women, even without the benefit of MRI, was really about half of what we had expected it to be. And I would say that's good news for patients.